Hi, I'm Melissa Hudson and also from St. Jude, and I'm going to review the gaps in the evidence base and research priorities for AYA oncology care, most of which have been previously at least mentioned within the last day and a half. And so as an overview, what I would like to do is highlight some of these gaps and the need to address these gaps in reversing the disparity in survival progress that is uh, standard for adolescent young adult oncology. And as illustrated in this figure where we see survival and 5-year survival progress in relation to age at diagnosis. And here you see the diagnosis, the era of 1975 to 80, compared with the blue line is 1993 to 1998. And we see that actually there was progress during this time for adolescent young adult oncology survival that actually exceeded, and there was an advantage compared to the childhood and older adult patients, but then this declined and we've lost this survival advantage. And so what is contributing to this and how can we remediate this situation? Well, we've heard over the last day that the AYA population is a unique population with psychosocial and medical needs associated with their cancer diagnosis that are challenging to the developmental phase. They're losing either their emerging or newly established dependents. They face a situation in which they're isolated from peers when peer support is critical. They have very meaningful concerns that are real about their future fertility potential. We have derailed in many cases their academic and vocational goals, and this whole experience may pose a threat to future health care and insurance access. So it's important that delivery of care to the AYA population respect communication preferences, and this involves some issues that we previously discussed too: information sharing with caregivers, involvement by caregivers in decision making, and importantly, these evolving modalities of communications that may not be familiar to us but are routine to this population. We need to, in our interactions with this population, acknowledge the need for independence and autonomy and address age-appropriate experimentation with health risking behaviors, particularly those that may compromise outcomes of their therapy. And we need to recognize that in particular that cancer treatment may have an impact on body image, sexuality, and intimacy that's quite important for this group. So let's highlight a couple of these gaps and some of the reasons for these gaps. Well, this figure shows a cancer histology prevalence by age, and we see that there is a distinctive distribution of histologic subtypes when one is considering childhood cancers. Most commonly, we are thinking of leukemia, central nervous system tumors, and lymphoma. In the AY age range, lymphomas are more prevalent, as are thyroid and germ cell tumors. And this is quite in contrast to older populations with cancer, where we would see lung, breast, GI, urinary tract cancers, et cetera. And because of this variable distribution and because of the environment in which these patients present, there is often a variable distribution of the source of care that actually can impact their outcomes. So let's talk about delays in diagnoses. And this was a study I actually was able to pull from the literature in trying to search what was more recently done. And this is a study that Dr. Blyer was involved with that addressed the diagnosis lag time, at which they defined as the interval onset between symptoms and signs and the date of pathology confirmation of cancer. And their cohort was from the MD Anderson and 270 cancer patients who were 15 to 29 years of age, evaluated between 2001 and 2003. They were able to provide information from a retrospective review that could identify a lag time in 88%. And this lag time was associated with the type of cancer as well as the health insurance status. And so one could see, and understandably so, that malignancies such as non-Hodgkin lymphoma, Hodgkin lymphoma, and leukemia were predictive of a shorter lag time, whereas those in relation to insurance, there was a substantially longer lag time in individuals who had public insurance versus those who had private insurance or were self-pay. And in cancers that were evaluable for stage at diagnosis, advanced stage disease was associated with longer lag times. And we know in particular this is a population that is struggling with maintaining, either achieving or maintaining their insurance access. So these are very pertinent results. And another study that we heard some of this information from Dr. Parsons yesterday, AYA participation in clinical trials is actually suboptimal compared to our pediatric counterparts. In a group of almost 1,400 AYA patients aged 15 to 39 years of age, that the data was derived from SEER as part of the NCI Patterns of Care study, only 14% of those were enrolled on clinical trials. And the enrollment on trial varied by diagnosis, such that there was a better enrollment with ALL and sarcoma patients and very poor enrollment among certain diagnostic types, such as germ cell tumor. The age at diagnosis also varied in the younger AYA, 15 to 19, I'm sorry, this should be 15 to 29. No, I'm sorry, that's right, 15 to 19, 34% were enrolled versus in older group, 35 to 39, only 3% were enrolled. Here we see a difference in race and ethnicity, and also a distinct difference in pediatric oncology versus hem-onc provider as being the accepting physician. And this is fairly standard within a pediatric operation. One would be enrolling our patients, if at all possible, on a clinical trial. And lastly, we can see the impact of insurance access on participation in clinical trials, with those with public and private insurance having a much larger participation rate compared to those who had HMO insurance or no insurance. This study also looked at median time to treatment and noted that the median time was actually only 3 days, which was surprisingly better than I thought it was going to be. The time to treatment did vary by diagnosis, and one can see here longer time frames for Hodgkin lymphoma, non-Hodgkin lymphoma, and ALL compared to germ cell tumors. And of course, germ cell tumors, because many of those individuals had low disease, limited stage disease, that surgery alone was their treatment. They did see a relationship between stage of disease, such that stage 3 compared to 4 had a fourfold excess risk of longer time to initiation of therapy. And there was a difference, too, in the facility in which the individual presented and was evaluated, in that outpatient versus inpatient had a threefold excess risk of longer time to delay. Now let's discuss some other disparities in AYA outcomes that may relate to a variety of factors, not just clinical trial participation. So this is a very nice review that was published in Blood in the past several years that addressed pediatric versus adult outcomes on clinical trials. And one can see that these are individuals with hematologic malignancies, and specifically, and this was Philadelphia negative ALL. And one can see a significantly better outcome for individuals treated on cooperative group pediatric trials compared to those treated on adult with the same disease, adult cooperative group trials. But it really is unclear in looking at these data, are these disparities due to differences in cancer biology? Because in many cases, it has been determined that some of these individuals have distinctly poor molecular features of their cancer, or is it the treatment approach in which pediatric centers may be more aggressive, may tend to give more long-term non-myelosuppressive types of treatment approaches, and also are more likely to include maintenance therapies? Or is it simply the environment of care where we're very paternalistic and we're tracking patients, and if they fail to show for therapy, we're getting them back in and trying to address the issues that are affecting their adherence to treatment? We've also had some discussions about the unique biologic differences of this population, and the thing that's very challenging is that not everyone is entering these same phases at the same time. It's very individualized, so one does need to consider organogenesis, the hormonal environment, the change in body composition that is occurring, with this rapid period of growth, increase in height and weight, the health behaviors that may impact cancer treatment, the use of other medications that may impact cancer treatment as well, like oral contraceptives, the compliance or adherence to the treatment plan, and the impact of BMI on drug disposition in the adolescent. So all these factors they present to us unique biologic differences that may affect outcomes that should be considered in the evaluation of these patients. And in regards to non-adherence, we actually had a very interesting recent study that was published by Body and colleagues based on COG results that evaluated adherence to 6-mercaptopurine in 327 patients with ALL, and they actually had a very nice distribution of both Hispanic and non-Hispanic participants. And the factors associated with the risk of non-adherence within this group were a longer time on therapy, older age, household infrastructure, having a single mother versus both parents, and ethnicity, Hispanic having a worse adherence. And what was concerning is that they observed a progressive risk in relapse, as demonstrated here, with time on study that was associated with the decreasing levels of adherence. So this also may be impacting our population in their suboptimal outcomes. What about health status? Dr. Ty shared some of these results with us, which just made me cringe, particularly when I saw the AYA prevalence of smoking from this behavior risk factor survey data compared to non-AYA populations. We also see some other suboptimal health behavior practices in regards to leisure time physical activity. They have a prevalence of conditions that are known to be compromising to health, such as obesity, cardiovascular disease, hypertension, asthma, that were all in excess of non-AYA population who did not have cancer. And then we see higher prevalence of conditions that affect their quality of life and sometimes their access to specific interventions such as disability, poor mental health outcomes, poor physical health. This is self-reported, and then a greater prevalence of those endorsing that they did not receive medical care due to cost. So this is, again, quite distressing within this population to see that they are showing divergences from normative populations that are not in the right direction. What about AYA survivor healthcare access? This information is from a study published in Cancer last year from Kirchhoff and colleagues, and again, it was based on 2009 behavior risk factor survey data from AYA survivors, in this case an older population, 20 to 39 years, who self-reported cancer at 15 to 34 years of age, and they compared this information to non-cancer AYA. So to orient you, AYA survivor information is in black versus controls in gray, and we're looking at proportions. And so here we see the AYA who reported no personalized medical provider with a significantly higher proportion in those that were underinsured who were survivors. AYA who's reported no routine medical visits in the past year with a significant proportion, a greater of those who were uninsured, and those who reported foregoing medical care due to cost in the past year with significant proportions in both insured and uninsured survivor population. Now, in looking at the same study at some sociodemographic information related to survivors who reported foregoing care, we also see here the proportion in relation to age, significantly greater in survivors in both age groups, sex, both significant in the female population, and across race and ethnicity, a significant greater proportion of those reporting foregoing care due to costs in those who were white. So in looking at AY healthcare utilization, we had some information presented yesterday related to preliminary results from the MEPS study, Experience with Cancer Survivorship. And just globally, I'll summarize some of the concepts that were presented. We again saw that there was a higher prevalence of chronic health conditions among AYA survivor populations. There was a higher prevalence of those endorsing they were unable to or had delayed necessary medical care. They reported higher medical expenditures, and they experienced greater physical limitations in relation to health-related unemployment, limited ability to work, and lost household productivity. And there were also disparities in access to care for those who were publicly insured and uninsured. So again, some concerning trends in what we see for our population who's already challenged after surviving a very critical illness. So globally, what I presented is there are a variety of factors that are contributing to disparities within this population for their survival progress. Delays in diagnosis of their primary cancer, inadequate access to and low participation in clinical trials, differences in tumor biology that have not been well studied in many cases, differences in body composition, hormonal status, and maturity of organs, non-adherence to treatments may play a role. Certainly, we've seen a theme over and over that this population has suboptimal access to medical and psychosocial services, and concerning information, too, that they lack awareness about cancer treatment-related health risks, and their health behaviors do not always reflect what would be a positive behavior in health promotion. So the bottom line is we know that cancer is a leading disease-related cause of death in AYA in the United States, and affects 8 times as many individuals between the ages of 15 and 40 as those younger than 15 years of age. We have a substantial prevalence of cancer and treatment-related morbidity within the AYA survivor population, And we also have had the beginnings of information presented to us showing that there is a substantial prevalence of unmet needs among these AYA cancer survivors. To address these needs, we really need to establish and adhere to the metrics for quality of care that have been promoted by the Young Alliance. And here, this importantly includes assistance with managing disease and treatment effects, cognizance among providers of the unique and psychosocial context for AYA growth and development, assessment of and attention to cognitive, psychiatric, and psychosocial needs of AYA, referral to available age-appropriate resources during treatment, and facilitation of the transition to survivorship. Now, we heard briefly from Dr. Fryer in the previous discussion about models of AYA oncology care. Optimally, that model would include someone with or individual with expertise in AYA oncology as well as expertise in AYA developmental issues. But we know that a young person's development is not always postponed in the event of a cancer diagnosis, so it's important to ensure that these aspects are revisited during the treatment journey. And this may be the optimal venue of care, but the available model of care may vary quite a bit based on the individual community. And as we heard previously, there may be cancer center-based care, community-based care, or a hybrid of this care. But since we know that these types of models vary in the community and vary in access to that survivor, it's not just the fabric or the environment of care, it's the ethos of care, recognizing that you are always going to be cognizant of these issues that are of importance to the AYA population. Importantly, AYA transition issues should be addressed, and some of the specific ones that need to be addressed prospectively include those that impact physical health, such as growth and development, how to promote healthy lifestyle, how to promote self-management and symptom management, how to address and reduce chronic health problems after cancer. In this population, it's critical also to address issues before therapy of fertility preservation, to acknowledge sexuality and its importance, address issues of contraception, other components such as sexually transmitted disease, the impact of cancer on fertility and reproductive outcomes, and sexual dysfunction that may result as a result of the cancer experience. Other important transition issues, mental health issues such as psychological adjustment to the cancer, their cognitive function, psychopathology, emotional well-being, how this experience has affected their goal attainment, and does there need to be a readjustment of goals, and how can we facilitate that goal attainment, and then health-related hindrances to those goals. An important component of social competency is the development of partnerships, intimacy, and marriage, and the cancer experience can certainly derail those, as well as other interpersonal relationships. How can we effectively reintegrate our survivors into social systems and assure that they have adequate educational progress and resources? How can we facilitate their vocational planning and achievement? And how can we assure that they have employment and access to health services and insurance that they need? I won't go through all of these, but health behaviors, again, is quite important to address within this population, not only at diagnosis and during therapy, but also in long-term follow-up, as we know that these types of behaviors may relate to or modify the risk of treatment-related complications. And health education is absolutely critical, as Dr. Fryer pointed out, in understanding cancer-related health risks, the types of self-management of those issues, the importance of adherence to screening and surveillance, and how to navigate the adult health care system, and how to utilize and maintain effective access to health care and insurance. So strategies to improve survival include education to enhance awareness, early detection, and diagnosis of AYA cancer and cancer treatment-related health risks. We need to establish and evaluate the care models to promote timely referral, initiation of treatment, attention to adherence and transition of care. We need programs to improve awareness of providers about the biomedical and psychosocial issues specific to AYAs, and some of those are educational in nature. And we need to develop AYA oncology research investigations. And this research that's going to close these gaps is going to be multifaceted. We'll be looking at survival outcomes, the biologic variations, the therapeutic approaches, and the location of care. And these need to be prospective frontline trials to really address these issues. The models of care, using and defining the appropriate metrics of care, care coordination, what can we do to facilitate transition, how that impacts utilization, access, and importantly, the cost benefit of these types of interventions. Health outcomes, both biomedical and psychosocial, are important, and we shouldn't forget that the patient and the survivor needs to be a component of this, because their self-reported outcomes are critical for us to really understand their perceptions of the experience on their overall psychosocial and medical adjustment. And then finally, we need prospective trials of interventions promoting adherence, self-management, and practice of health behaviors that are going to reduce risk of disease long-term and promote adherence to health screening and surveillance. So I will stop there and be happy to answer questions at the panel.